Good evening, everyone. This is Dr. Rowena Kawili, your host and moderator for today. We will now start our program with an invocation. This will be followed by the national anthem, then our PPS hymn.
Mga kababayan, ang pambansang awit ng Pilipinas.
Doc Weng, wala kayo audio?
Hello.
Hello. Good evening. Jay, can you hear me?
Mahina, Doc.
Wala, Jay. Hello.
Can you hold close your microphone na lang, Doc?
Good. Hello.
Yes, Doc, we can hear you, Doc.
Okay. Okay, I'm sorry. Good evening once again. Is my audio clear now?
Yes, Doc.
Okay. I'd like to welcome everybody to our 5th chapter-initiated webinar. May I call on our president of the PPS NCM chapter, Dr. Amelita Maria Hamoy, to give us the opening remarks.
Thank you, Weng. Good evening. Welcome, colleagues and friends, to our webinar entitled Approach to a Bleeding Child, Relearning the Basics. Hematologic disorders, especially bleeding disorders, often present with active bleeding, petechia, or hematoma. Most often than not, a bleeding child is immediately brought to the ER, but those who present with petechia or hematoma are often missed. Possibly some of you may have received calls from parents or mothers because of bleeding. For us doctors, bleeding in our patients poses a challenge in terms of lab workups and diagnosis. They may appear simple, but sometimes they may become complicated. Tonight, we will be presented with common cases that we might see in our clinics and how to go about the laboratory workups. So together, we will relearn the basics. Before I forget, let me greet all Iliganans a happy fiesta. To everyone, keep safe and don't let the pandemic bring you down. Together, we heal as one. A pleasant evening, and may we have a fruitful night ahead of us.
Thank you very much, Dr. Hamoy. Before we start our lecture, let me just remind our attendees of our house rules shown on the screen. Okay, so please stay until the end of the program to access the... Can you see my slides?
Loading, Dr.
Okay, so let me just remind our attendees to stay until the end of the program to access the CPD quiz and to get your certificate. And during the open forum, you may type your questions in the Q&A box located on your Zoom panel. When answering the CPD quiz, make sure there are no typographical errors in typing your email address and your name. And for questions about your CPD certificate, you may email us at ppsncmcpd.cpd2020@gmail.com. Okay, so without much ado, let me just introduce to you our speaker for tonight. He is a fellow of the Philippine Pediatric Society, a fellow of the Philippine Society of Hematology and Blood Transfusion. He's also the fellow of the Philippine Society of Pediatric Hematology. a past president of the PPS NCM chapter. Presently, he is the chairman of the Department of Pediatrics, Maria Reina Xavier University Hospital, and he's the head of the Hematology Oncology Unit of the Northern Mindanao Medical Center. Ladies and gentlemen, colleagues, let us all welcome our speaker for tonight, a debonair gentleman and a very talented artist as well, Dr. Fernando Douglas Go. Hello, Doc.
Hi, good evening, Weng. Good evening, everyone.
Evening, Doc.
Thank you, Weng, for that very
You may
kind.
start anytime, Doc.
Yeah, I will start my screen share. Okay, can you see my slides?
Yes, Doc.
Okay. So, good evening, everyone. Again, thank you, Weng, for that very kind introduction. I hope everyone is safe and in good health, with the current pandemic. And of course, I would like to thank the chapter for inviting me to talk on this topic, which I know everybody knows, but probably just need a review. As mentioned by our president, most of us are intimidated, or whenever we are confronted with a patient, or it poses as a big challenge, if you're confronted with a child who is bleeding. Okay, so I hope this lecture will, in a way, ease the degree of intimidation. It's not really as difficult as it may seem. Okay, so here are the objectives of this lecture. Of course, we have to review on hemostasis. We will discuss the basic principles in diagnosing a child with bleeding. Okay, discuss necessary laboratory tests. So hematology is really laboratory dependent. So we will be discussing what are the important laboratory tests to do. And then we will be discussing a few common bleeding disorders as mentioned by Baby. And lastly, I hope that by the end of the lecture, you'll be able to learn to identify, which patients really need hematology referral. I know during this time, it's very difficult how patients come to a subspecialist for referral. So if you could manage these patients in your clinic, then so much the better. But before anything else, I'm going to, I have some survey questions actually, so that I will have an idea as to how we are faring in terms of managing our patients presenting with bleeding. So the first survey question, so this is a poll question, so try to answer the questions as honestly as you can. So the first is, what is the average number of pediatric patients that you see in a year? I just put there in a year because I know it's not really that much. So I see 112 participants, so I guess that's a good number. So I would have an idea as to the general consensus of our chapter. So maybe I'll give you 15 seconds to answer the poll question. Okay, can we have the results, PJ? Okay, so most would belong to the 1 to 15 years of age, no? So 61%. Okay, so mostly, if majority would be between 1 to 10 years old. Okay, so next, please, the next poll question. Usual age group. So 0 to 1, 1 to 5, 6 to 10, 10 to 18. Okay, PJ, can I have the result, please? So majority would belong to the 1 to 5 years old. So next poll question. Next survey question. So the usual bleeding problem that you see in the clinic is in the form of any of the following. No? So you can choose as many as you deem necessary, or as many as you, whatever usual cases that you see in your clinic. Okay, so PJ, can we have the result, please? So majority would be in the form of epistaxis. Okay, that's very interesting. And PTK. PTK would come next. And then hematomas, 55. Okay, GIB, could you, okay, never mind. So the next, okay, gum bleeding is 44%. GI is 29. Okay, next, next poll question, please. We'll go to the next poll question. So here I would like to know what laboratory tests your laboratory is capable of doing in your area. So you can choose again as many as you want, as many as what is available in your center. Okay, so can I have the result, please? So of course, everyone can do CBC, take count, not all. Clotting time. So bleeding time is 85, torsion bleeding time. So this is 88%, 81. So except for repeat count, no? I guess all of the tests are available in your centers. Okay, so the last poll question. So confronted with a bleeding child, which of the following tests would I request for? So it's practically the same test that I mentioned in the previous slide. So if you have a patient coming in with bleeding, which among these tests would you do initially as an initial test? Okay, so can I have the result, PJ, please? Of course, everyone will do a CBC. Bleeding time. Okay, so okay. So anyway, thank you for answering the poll questions. You will actually know the relevance of your answers as we go along with the discussion. So we will know. You will know if your answers are correct. No? So first we discuss. So what is hemostasis? So when does bleeding start and when does it stop? So, and this is what practically hemostasis is. No? From the time you start bleeding until the time your body would stop to bleed, and that is actually the process of hemostasis. So basically what happens if you have injury to your blood vessel, the first thing that would really happen is you will have vasoconstriction. Okay, so this is actually the first phase of your hemostasis. This is phase 1, which is the vascular phase. And the purpose of this is to decrease the blood flow to the area of injury. Okay, in a way, it is a defense mechanism so that we won't be losing more blood. So after the vascular phase comes your platelet phase. And this is where your platelets play a role. Okay, so this is when your platelets would initially adhere to the site of injury and eventually aggregate with each other to form your temporary hemostatic plug. So as the term implies, it's something temporary. You need a cementing substance to make that clot a stable clot. It's just like, you know, making a brick wall. If it just all bricks with no cement, then with just a slight push, that brick wall would crumble. No? So you need to have another thing, no, to make that make that temporary clot stable. And this is where your coagulation factors come in. And this is your so-called plasma phase of hemostasis. So the coagulation factors would try to cement the platelets that have adhered to the vessel, to the site of injury of the blood vessel. Okay? And of course, the last phase would be your fibrinolysis. Okay? So the body also has a mechanism of removing the clot. That clot cannot stay in that area forever, because if it will stay there, it will become a thrombus or a site of obstruction. So there's a way of cleaning that area to become that area of injury smooth again. But our discussion will be focused on these three phases. Okay, so try to remember these three very important phases, because if you understand these three phases, then you will know how to go about in the management of your patient in terms of diagnosis, in terms of history and physical exam, as you will know in a while. Okay, so we'll focus on the vascular phase, platelet phase, and the plasma phase. So first and foremost, of course, is getting a good history. So just like any other condition, history is very important. So history and actually physical exam. Okay, so age of onset is very important. Okay, there are conditions wherein bleeding would start early on. So it could give you a clue if this is something congenital or hereditary. Okay, so if it starts early on, then most likely it is something uridofamilial, no? Although not in all cases. Okay, so sex is also very important. We know very well that there are certain hematologic conditions which are seen only in certain sex population, or like for example hemophilia. Okay, again, family history. So you have to make even a good family pedigree. So at least 2 generations up to look for any signs of history of bleeding in the previous generations. Okay, severity of bleeding. Okay, patients with menorrhagia, it may not be primarily hematologic, it could be gynecologic. So you have to rule out also all other causes. Okay, so history of prolonged bleeding after surgery, like I had a patient before coming in post circumcision, and turned out that patient had hemophilia. So of course the patient bled, no, on the circumcision site. And another is drug intake. So try to ask what the patient's been taking the past few days. So aspirin is very notorious for causing platelet dysfunction. No, actually platelet affects the function of your aspirin affects the function of platelet. It doesn't affect the number. And the onset of action usually of aspirin is as early as 20 minutes. No? So 20 minutes after intake of aspirin, especially the non-enteric-coated, would be very fast, no? As fast as 20 minutes, whereas the enteric-coated would take effect after around 3 to 4 hours. And when you stop the medication, its antiplatelet effect would last up to 4 days. So very important for you to know this, because sometimes, you know, we are told to clear patients for OR and they have been on aspirin for quite some time for some reason. So maybe you have to wait for 4 days after the intake of aspirin before you clear that patient for surgery. Okay, so another would be concurrent medical problems. Okay, so patients having sepsis, especially if they went into septic shock, they would go into metabolic acidosis. Metabolic acidosis would eventually lead to the IC. So these medical conditions could predispose the patient to bleeding. Okay. And one very important aspect also to consider would be, of course, if it's secondary to trauma. Okay? And one very important aspect to ask in the history is child abuse. So which is actually based on the statistics with the current pandemic, with everyone staying in the house, there is I think a 30% increase in the incidence of child abuse with the current pandemic. So actually, this is just a data on child abuse, which I got from this is from national data, although this is a bit old, 2016. I was not able to get a newer one. So physical abuse is one of the most common cause of child abuse, no, presented. It comprises 66%. And locally, I was able to get some data from the Northern Mindanao Medical Center, CPU. Okay, so thank you very much to our resident, Dr. Aldo Purig, Dr. Nicole Yap, for taking time to collect this data, and of course to Dr. Lourdes Mendoza, the head of the CPU, our CPU, and of course the chairman of the department, Dr. Lagunilla, for allowing me to make use of this data. So physical abuse is second in rank, in terms of the type of child abuse. And among those who had physical abuse, 99% of them, 99 of them presented with bleeding. And usual age group is between 10 to 15. So, and usually it involves the head and neck area. So what are the telltale signs of a patient with child abuse? So try to look at the history, try to get a good history. So usually there is no history or a denial of trauma, despite the patient presenting with severe injury. The significant other will really deny the patient being exposed to trauma. So there is an implausible history for degree or type of injury. For example, you have like a small child, like a 12-month-old or 1-year-old child who had scalded burn. The parent would say that that child turned on the hot water faucet. So how could a 12-year-old child who could even barely walk, turn on that faucet? So that could be an indication that the significant other is lying. Okay? So of course, an unexplained or excessive delay in seeking care. And this could be manifested by, a lot of injuries. When you do physical examination, if you have trauma, you have different areas of trauma with different ages, some are healing, some are new. And it means to say that this thing has been going on for quite some time. Okay, injury attributed to home resuscitation efforts. Okay. So if there is an inconsistency in terms of the giving out of history from the significant others in the family, from the caregivers. Or if the parent would say that it is something self-inflicted or it is caused by some of the other children or pets. Okay? So if you have any of these signs, red flag signs, then try to think of child abuse. So physical examination is very important for you to determine the possible etiology, the possible cause, and it will also help you in deciding as to what workup to do. No? So it could either be mucocutaneous or it could be a deep-seated bleeding. So just think of these two areas, because just by knowing the area of bleeding, it will already give you a sign or an indication as to the type of condition you're dealing with. No? So here is the table which will differentiate between a purpuric disorder from a disorder secondary to coagulopathy. No? So purpuric disorders involve the vascular and the platelet phase. If you remember the hemostatic mechanism that we discussed earlier, you have the vascular and platelet phase. So if you have vascular and platelet phase problems, usually they would present with purpuric disorders. Coagulopathies, on the other hand, which involves the plasma phase, would present with this clinical manifestation. So usually, if it's purpuric, manifestation would be usually mucocutaneous or ecchymotic. No, usually it's superficial bleeding, petechiae, ecchymosis. Whereas if it is secondary to a coagulopathy, most often it is a deep-seated bleeding. So you have to remember that purpuric disorders, superficial bleed, coagulation disorders, which involves plasma, your coagulation factors, usually will present with deep-seated bleeding, okay, like hematomas, hemarthrosis, as seen in patients with hemophilia. And you could also have delayed bleeding. The rebleeds are usually common in patients with coagulopathies. The rebleed is because of, if you have injury, initially the bleeding will be controlled by the platelets, but eventually if that platelet will not be cemented, no? So to speak, by your coagulation factors, it will eventually be lysed. So there would be secondary bleeding. And this is an indication of a coagulopathy. In physical examination, of course, you know how to differentiate between a petechia, a purpura from an ecchymosis. Okay, so petechia usually is less than 3 millimeters. And one thing which we have to differentiate a petechia from is from an inflammatory condition, no? Like an insect bite. How do you differentiate a petechia from an insect bite? So a point of differentiation is blanching. PTK will not blanch on pressure, whereas if it is secondary to an insect bite, you apply pressure to that lesion, then that lesion would blanch. Okay? So purpura would be something bigger, more than 3 to 10 millimeters in size. And of course, ecchymosis would be a lot bigger, and they would tend to coalesce with each other. So if you see a patient like this, think of a purpuric disorder. Whereas if on physical examination, you see a hematoma, or like this one, you have swelling of a joint, which is an indication of hemarthrosis, no, or bleeding of a joint, then think of a coagulopathy. But of course, you have to look for other signs and symptoms, no, like adenopathies or ganimegalies, to rule out other like lymphoproliferative disorders. That's also part of the physical examination. Okay. So if I look back into the survey question a while ago, the most common cause of the most common form of bleeding that is seen in your clinics is actually epistaxis. No? So it's 83%, which is actually true. Very common. And these are the usual causes. Okay? So it's dry air, no speaking. Among the patients that come to my clinic for referral, most of them really have allergies, allergic rhinitis. So it is quite common, and most often it is not severe, and most often it will just resolve spontaneously, and it doesn't really require hospitalization most of the time, as I'm sure everyone of you has experienced. So most often it will just need reassurance, but of course in some instances you have to do some workup, most especially if it is that severe, or if the bleeding is really that profuse and very recurrent, and you have to do further workup. So if you look at the Philippine PPS, if you look at the PPS register of diseases, we have, it's not really that high, but these are admitted cases. I'm sure if you look at the cases, this is more of an OPD. If you look at the OPD census, then I'm sure it will be a lot more. So, but then again, you have to remember that epistaxis is rare in children less than 2 years old. So if you see a child less than 2 years presenting with epistaxis, then consider trauma, whether intentional or unintentional, or probably it's really something hematologic. So you have to work up this child. If the child is less than 2 years old. So now we go to the laboratory tests. So this is most of us really, as we got from the survey, So really, it's really part of our workup to do laboratory tests. And I would agree with everyone that CBC platelet count would really be top among the list. No? You have to do a complete blood count, a platelet count. Of course, if the platelet count is low, then that's already a clue that there is really something pathological going on. CBC, if you have a high count, try to look at the white cell count, try to see if there is anemia. So peripheral smear is also very important because in the peripheral smear, the pathologist will see morphology. If blasts are seen, normal cells are seen in the peripheral blood. If the platelet count is few, then that is already an indication that there really is something wrong. And of course, a reticulocyte is very important. The retic count is an index of bone marrow function. If it is low, it is telling you that the marrow is not compensating. If there is anemia and if you have reticulopenia at the same time, it means to say that your bone marrow is not compensating for the anemia. So actually at this point, I would like to share with you some, maybe I could call it a trade secret. If you're given this type of laboratory examination, no? This is actually not in the books. If you're going to read books, it's not in the book. So this is sort of a trade secret. Okay? So if you have a patient coming in with leukocytosis, if you are given a result, like this, you have leukocytosis with anemia, thrombocytopenia, and especially if there is already a peripheral smear review coming in with it and showing blasts in the peripheral blood. But of course, if you do physical exam, you have nodes, adenopathies, then bread and butter diagnosis will be leukemia. Okay? You won't be wrong about that. So you refer that patient to me. Okay? So, and then next would be if you have, if everything is low, okay, white count is low, red cell count is low, and you also have reticulopenia. I mean, if you have pancytopenia, okay, so the word for that is pancytopenia, then the first thing that you have to consider is bone marrow failure, so like a plastic anemia. And then the last, probably trade secret would be if you have isolated thrombocytopenia, child clinically well, no adenopathies, the peripheral smear, the white cell is normal, there is no anemia, the peripheral smear is very, I mean, aside from the very low platelet count, there are no blasts in the peripheral smear. And the first thing you have to think of is ITP. So try to remember this, it will really help you a lot. So the next would be coagulation studies, of course, no, your growth time, okay, so all of this. If the first three turns out normal, then probably you have to proceed to this coagulation. So this is your coagulation cascade. I know everyone hates this diagram. I'm not very fond of it myself, but it's a way of making us understand, no, where our pro time or PPTP would fall, no, in relation to this coagulation cascade. So as a review, we have the intrinsic pathway and the extrinsic pathway. So, and there are different coagulation factors which are involved in these two pathways. So the intrinsic pathway is measured by the activated partial thromboplastin time, or our ATPT. And the intrinsic pathway, which involves your vitamin K dependent factors, your 2, 7, 9, 10, is measured by the prothrombin time. So your intrinsic pathway, if it's prolonged, then you have to think of these coagulation factors, like your factor 9 and factor 8, which are involved actually in patients with hemophilia. Okay, so again, prothrombin time, it measures your vitamin K dependent factors, which is actually formed by your liver. So patients with prolonged pro time, usually it's even an early indication of liver failure. And as I mentioned, it is a measure of your extrinsic and of course your common pathway. So prothrombin time, this is also very important, no? Because it's also very important that you know how to interpret most of the common mistakes that I see in practitioners is they make use of the percent activity in interpreting the prothrombin time. Okay? So if it's less than 100%, like in this case, if it's 68%, then they would already worry. But it's not really the percent activity which is important. So what's important is the INR, no, or the International Normalized Ratio. So this INR is actually computed by the laboratory. So it is actually reagent dependent. So you don't even need to look at the normal value. Okay. So it's the INR which is important, which should fall between zero point 0.8 to 1.1. No, if it's beyond 1.1, then that is prolonged. No? So if it's below zero point 0.8, then it's really fine. No? But we are more concerned of a prolonged prothrombin time. So what are the conditions with prolonged prothrombin time? So these are the conditions, as I mentioned, liver disease, vitamin K deficiency, patients receiving warfarin therapy, APAS, and DIC. Vitamin K deficiency is common in patients with malnutrition, patients on prolonged antibiotic use, or in patients with fat malabsorption. Okay. Of course, warfarin, it inhibits vitamin K, the vitamin K dependent factors. So these are common usually in adults receiving anticoagulant treatment. Of course, in DIC, you have prolongation of both your prothrombin time and your APTT. Since in DIC, you have disseminated intravascular coagulation. So practically all the coagulation factors are consumed. So you would expect prolongation of both prothrombin time and the activated partial thromboplastin time. So APTT, as mentioned earlier, it measures activity of the coagulation factors in the intrinsic pathway and the common pathways. So normal value is between 30 to 40 seconds. So conditions presenting with a prolonged activated partial thromboplastin time, of course, very common is your hemophilia A or coagulation deficiency, and your factor 9 deficiency, which is hemophilia B. Your APTT actually is a good screening test for these two conditions. Once this is positive, then sometimes it is important to do further assay for each particular coagulation factor. So coagulation like factor 8 or 9 assay, you have to proceed with that if you have a prolonged APTT, and then you are considering hemophilia. So as mentioned, it is also prolonged in the IC. So next would be bleeding time. If I look at the survey, bleeding time, 42, a good number. Most of the laboratories are capable of doing bleeding time, and a lot of us, practically half, no, are also requesting for bleeding time. And one thing you have to think of if you're considering bleeding time is this is the traditional way of doing it, the book method. Okay? So the medtech would make a prick in the finger and then blot it with the finger. This actually is that the correct way of doing bleeding time. So this is thought with a lot of false results. So the proper way of doing bleeding time, the ideal way of doing bleeding time is through the template or the IV method bleeding time. Okay, so this involves the use of a bleeding apparatus. So you have to maintain the blood pressure at 40 millimeters mercury, or the pulse pressure if ever you're dealing with a child. And it makes use of this special lancet, which gives a standardized incision over the molar aspect of the forearm. There are actually two lancets available, one for adults and one for children. But the problem is, actually, I tried to look at all the hospitals in the city in Cagayan de Oro. There are 9 hospitals. Only one is capable of doing the template method IV bleeding time. So if you cannot do it the right way, better not do it. Okay, of course, you could always look for other means of evaluating your bleeding time. Actually measures your vascular integrity and platelet count, no, and the platelet function. If you have prolongation of your bleeding time, it means to say you have some degree of uh, defect in vascular integrity or in the platelet count. No? Okay, so this is how it should be done. So these are the conditions wherein the bleeding time may be prolonged. Of course, in collagen disorders wherein vascular integrity is compromised, patients with either quantitative or qualitative platelet disorders, your von Willebrand's disease, if you have a hypofibrinogenemia, and in patients with severe anemia. So, and then next would be clotting time. Actually, until now, this test is still being frequently ordered. Okay? So actually, again, almost half of the responders are still requesting for the clotting time, and practically like 85% of the laboratories are still doing this. So it's the slide. They do it this way, they put a drop of blood in a piece of slide or in the capillate and then time until the fibrin clot will be formed. So this is actually very erroneous because once you expose blood to glass, it will be already activated. The coagulation cascade will be activated. So actually this test is no longer really being recommended. No, it's an obsolete test which should no longer be requested for. So if you really want to determine coagulation activity of your patient, better do your pro time and your APTT. So this thing you have to remember. So I don't know how we could really remove this from the system of doctors. No? Even surgeons, obstetricians request this test pre-op. So, and it's very difficult to change an old practice. But now at least you know that this is something we should no longer request for. So this table just shows that there could be some differences, in the values, especially in infants and neonates. A lot of us are dealing with infants, neonates. So actually for platelet count, most infants and neonates would have platelet counts similar to adult values, or maybe it could just be in the lower level of 150,000. The difference would come in terms of your coagulation studies. Okay, so most often neonates and infants less than 6 months would have a more prolonged result when you do ProTime and APTT. Above 6 months, then most often it would already be similar to adult values. So the cutoff is 6 months. 6 months and below, you could have more, you could have higher results, you could get higher results. Okay, so this is just an algorithm, a summary of what we have discussed. Okay, so if you have a child coming in with bleeding, get a very good history and physical exam. Of course, do your tests. Your basic test initial is your CDC peripheral smear. And remember our trade secret that I have shared to you. And then depends, if this is really normal, if you have to work up further, then depends on your physical exam. If it's a mucocutaneous bleed or a purpuric disorder, okay, you have to correlate with the platelet count. Okay, if you have template bleeding time, then you can do it. Okay, and of course there are really platelet studies, like aggregation studies, which ideally should be done if you're considering a defect in platelet function, but we don't have it available here in the locality. Of course, it is available in big centers in Manila, but not even all of the centers in Manila can do it. NKI actually could do platelet aggregation studies. But don't worry, this is for the hematologist this is actually the concern of the hematologist already. So if it's a deep-seated bleeding, then proceed with your coagulation studies. Okay, next. So now we will be, I will be presenting a few cases, no, for you to diagnose. Okay, so this is a 12-year-old girl presenting with petechial lesions over the trunk, upper and lower extremities, with no associated fever, and is clinically well. No? Patient is just up and about. But this patient had a history of tonsillopharyngitis 2 weeks prior. Okay, so this is the hemogram of the patient. Hemoglobin, there is no anemia. White cell count is very normal. Okay, there are no blasts seen, except that the patient really has a low platelet count. So what would be your diagnosis? So can I have a question? So I guess this is very easy. Everybody, I guess, would get the correct answer. So can I have the result, please, PJ? 97. Okay. So almost everyone got it. So SLE, somebody answered SLE. So you have to look at there are other parameters, no, for SLE. Of course, SLC could correct. It could present with thrombocytopenia. Allergic rash definitely doesn't present with thrombocytopenia. Okay, so next slide. Could you close the window, PJ? So answer is ITP. Okay, so you're correct. Hmm? So ITP, so we often refer to this as idiopathic thrombocytopenic purpura. So this is also something which I would like to probably refresh everyone. No? This is a matter of terminology, but ITP doesn't really stand for idiopathic thrombocytopenic purpura anymore. So why not idiopathic? Because we know very well that the etiology is immunologic. It is an autoimmune disorder. Okay? And some patients with ITP may not present with bleeding. They would just present with a low platelet count, and some of them may not even present with the PTK, and it's still ITP. So that's why the new term now is immune thrombocytopenia. No, the I, the T, and the P are still there, but it's now immune thrombocytopenia. So next time you make a diagnosis, you use this term. Okay? So this is actually the most common. This is a very common hematologic disorder that we see in our practice, and most often it is post-infectious and even post-vaccination, and we know that very well. And this is because of immune dysregulation. Okay, so anti-platelet antibodies will destroy the patient's own platelets. And since this is a problem with thrombocytopenia, it is a quantitative platelet dysfunction, it will present with mucocutaneous bleeding. It will affect the first phase, the platelet phase rather, of the coagulation cascade. And this would often present with isolated thrombocytopenia. Okay, so statistics-wise, so I got some data from NMMC. This is a one-year data last year. So ITP is really top in the list, no? And even in my private practice of 20 years, so it's also top among my list of hematologic disorders. So ITP could either be acute or chronic. So acute actually is more common. It is seen in practically 70 to 80% of cases, while 20 to 30% is chronic. No? So how do you differentiate acute from chronic? It's of course, the chronicity for the platelet to be thrombocytopenic. You know, the length of time wherein that platelet count would not really go back to normal. If the thrombocytopenia would persist up to a maximum of 1 year or beyond 1 year, then that is already considered chronic. So acute ITPs would most commonly resolve within a maximum of 1 year. Beyond that, then you can label that as chronic ITP. Acute ITP is more common in children. There is no really sex predilection for, not much, although here it says it's more male over female. Etiology, it is secondary to infection, vaccination, as we have mentioned. And as for the chronic type, it is secondary to antibodies directed against the platelets, glycoprotein complexes. So in the chronic type, there really is some derangement in the structure of the platelet, making it appear as non-self. So that's why the antibodies, the patients on antibodies would tend to destroy it, because the configuration of the platelet is already changed. No? So it will not be identified by the immune system as being self. Okay, so for the course, of course, acute, it will just resolve spontaneously, whereas for chronic, of course, it will be persistent. So again, so case number 2, this is a 6-year-old boy with recurrent swelling over the left knee joint, noted around a year, when the child, year old, when the child started to walk. So these are the laboratories of this patient. CBC is very normal. Pro time is also normal, but if you look at the result with the APTT, the result is very much prolonged, almost twice the control. So what would be the considerations? Okay, can we have the result, please? Okay, so I guess everyone, almost 90%. Okay, almost everyone got the result. JRA doesn't present with a deranged coagulation study. So definitely it's not JRA, no? It's hemophilia. Okay? Hemophilia with hemarthrosis. So what are the clinical manifestations? In the newborns, it could present as an intracranial bleed, bleeding from a circumcision site, as I mentioned earlier, or CC bruising, and usually it's deep-seated bleeds, since it involves the third stage of coagulation, or your plasma phase. And in some cases, you could have a target joint. A target joint is a joint which is the site for recurrent bleeds. Like if it's the right knee, then it's the right knee which would have recurrent bleeds over and over again, which is quite common in some patients. So hemophilia, 2 most common types would be your hemophilia A, which is deficiency of your factor 8, and hemophilia B, which is deficiency of factor 9. Actually, both of them will present clinically the same. The difference only would be when you do a test. But more common among the 2 is factor 8. Practically around 80 to 90% of our hemophilia cases are because of deficiency of the factor 8, or your hemophilia A. Factor 9 deficiency is less common. So laboratory test would be to do an APTT and of course do a factor assay. And severity can be determined by doing factor assay. If the factor level is less than 1%, then that is severe. More than 5% is mild. So the next case is a newborn. This is a 4-hour-old female neonate born 38 weeks, age of gestation via cesarean section due to severe maternal preeclampsia. Patient was slightly small for gestational age, 2.5 kilos, and a bit depressed, with an upper score of 6, 8, and 9. But the patient at 4 hours old was apparently well, not in distress, with good suck. But there were a few petechial lesions noted over the anterior neck. So no maternal illnesses or infections were noted. Maternal CBC was normal. This is the hemogram of the patient. showing thrombocytopenia of 80,000 per cubic mm. The coagulation studies were very normal. So what would be the diagnosis for this 4-day-old SUA? Appearing very normal except for the isolated thrombocytopenia. I guess some of you have seen cases like this. So can we have the result of the poll? Okay, so 63% answered early onset neonatal thrombocytopenia, and a good number, no, a third percent answered congenital ITP. So which of this is the diagnosis? Okay, so can we go to the answer, please? So this is actually a case of early onset neonatal thrombocytopenia. And commonly this is because of placental insufficiency. Actually, the hypoxemia in a way would tend to cause bone marrow suppression, so leading to decreased production of your platelets. And most often this will present with mild moderate thrombocytopenia and would often resolve spontaneously, even without treatment, within 7 to 10 days after birth. So I don't know if some of you have seen cases like this. Hey, sorry. Some of you answered congenital ITP, which is actually also a good choice, but I really intentionally emphasized in the maternal history that the mother, they didn't have any medical illness and the CBC was very normal. Usually in patients with neonatal autoimmune thrombocytopenia like congenital ITP, which is secondary to maternally inherited autoantibodies, which will attack also the infants, the newborns' platelets. Usually there is a history that the mother has also an ITP or probably lupus or other autoimmune disorder. Okay, so if you have a patient, so it's why it's very important if you have a patient coming in with a newborn coming in with thrombocytopenia, it's really worth asking, if the mother, worth asking for the mother's CBC result. So, or if there is any medical condition, like has been mentioned, like lupus or any connective tissue disorder, because there could be maternal antibodies which goes into the circulation of the fetus, causing like a form of actually mechanism is the same as ITP. But the platelet levels here eventually normalizes at age 10 to 60 months. Since the antibodies have a half-life, usually antibodies would stay in the circulation for like 3 to 4 months. So usually by that time, once the system is already rid of the antibodies, then this condition would eventually resolve. Okay? So in some instances, you really need to give immunosuppressives. So I won't be discussing management anymore. So this is just a table showing to you the different possible conditions of neonatal thrombocytopenia. Maybe focus on this area, which are the common forms, common causes. Okay, so for preterms, of course, sepsis is also one of the differentials, but quite common for the two, early for both early onset. I mean, even for terms, is placental insufficiency or hypoxemia or some degree of asphyxia is common in both. So you have to consider these other differentials if you're confronted with a newborn patient with thrombocytopenia. Okay, next. So this case, I'm sure you have seen a lot because I get to see a lot of referrals of this kind of patient. No? A 5-year-old boy with recurrent hematomas, quote unquote. And the hematomas are very unusual in appearance. They have pale nodular centers. And if you look at the laboratory, that very significant eosinophilia. So I guess at this point, everybody knows already what the diagnosis is. So anyway, here are the choices. So is it secondary to trauma? Is it ITP? Is it hemophilia? Or is it acquired platelet dysfunction with eosinophilia or your so-called APDE? Okay, PJ, can I have the result of the poll, please? Okay, very good. No? Most of you got the answer. It's actually acquired platelet dysfunction with eosinophilia. I understand a lot of you, I received actually a lot of referrals, and what I put in the diagnosis is allergic vasculitis. So actually the proper term to use is acquired platelet dysfunction with eosinophilia. Okay, it's a term. Actually, this condition has been discovered several years ago, no? And it is quite common in Southeast Asia. And usually, for some reason, actually, it's not known why it's common in our area. And the pathogenesis, actually, it's rheumatic. And there is some potential that it is a form of hypersensitivity reaction, okay, a type 1 hypersensitivity reaction. So the lesions are chemotic, seen over the trunk and extremities as what was seen in our picture. And most often there is really eosinophilia. So the reason that maybe parasitism could be a factor, aside from it being a form of atopic disease. And there is some evidence of platelet dysfunction. Actually, if one is to do platelet studies on a patient with APDE, then the platelet function test would really be deranged. But even on morphology, there is a certain morphologic character of patients with APDE in terms of the appearance of the platelets. No, the platelets would appear gray. No, if the pathologist is really observant, then it's important to look at platelet morphology. But even without doing platelet morphology, just by looking at the lesion itself, if you get a very strong family history of atopy, if you look at the family background, there is asthma, there is allergic rhinitis. Then you look at the CBC, there is eosinophilia, no other signs of lymphoproliferative disease, then think of this condition. So prognosis is generally good with a benign clinical course, and it would usually resolve in 3 to 6 months. So very important is to give reassurance, no, to the mother that this is something temporary. It's not a leukemic process, no? And then try to identify what possible offending allergens are involved. No? Maybe you could give antihistamines, you could be warm, okay? But doesn't really matter. Most often it would just resolve. So actually for the past 20 years, I have seen around 150 cases of APDE referred to my clinic. So anyway, this is the last case, also an interesting one. I also get this as a referral from most of you. So these are actually 3 to 5-year-old kids. I'll be showing pictures of 3 kids, around 3 to 5-year-olds, presenting with well-demarcated round to oval, dusky, red to brown black macules over different areas of the body. No? So see these lesions, very typical of this disease. And there is a history of intake of a drug, no? Most often cotrimoxazole, every time the patient has fever. The cotrimoxazole is often used in the health centers, and sometimes mother would have the notion that if their patient or if their child has fever, then they would give cotrimoxazole right away. So these are the lesions, and the child is clinically well. The laboratories are very normal. You don't even have eosinophilia. It's practically normal if you do a lab test. So what could be the differential diagnosis for this condition? Okay, PJ, can I have the result, please? Okay, so I guess almost everyone got the right answer. 69%. It says it's fixed drug reaction. Some would say it's SJS. Of course, SJS could be a differential erythema multiforme. So anyway, the answer is actually fixed drug reaction. In SJS, the lesions are less defined. No, they have less defined border with tendency to coalesce, and usually the mucous membranes are involved in over 90% of cases. Here, the mucous membranes are not involved. And in erythema multiforme, usually it is rarely drug-induced, and the lesions are different. They are target lesions. Moramortia target lesions consisting of 3 components, no? A dusky central area of blister, a dark red inflammatory zone surrounded by a pale ring of edema. Unlike this one, it's just homogeneous. And there is a tendency for recurrence on the same site. If that patient, if the lesions would just fade off, and then the next time the patient takes that drug again, that same site would flare up and become dark again. So that's why it's called a fixed drug reaction. So this is actually a cutaneous reaction, recurs in the same location upon exposure to offending drug. So it could be immediate or a late reaction. And again, it's something immunologic. So it can occur within minutes or even up to weeks, like 2 weeks after the exposure of the offending drug. So what are the drugs implicated in this condition? Okay, antibiotics, most common is cotrimoxazole. Of course, ibuprofen, you're a fan of giving ibuprofen, and even paracetamol is notorious for causing this condition. So in my practice, I've seen like 47 cases of fixed drug reaction. It has been referred to me. Okay, so as a summary, okay, always remember that most bleeding conditions in children are benign. So don't panic, no? If you have a patient coming in with a hematoma or a bruise, most often it is not something really that serious. Okay, so history and P is very important. And of course, you don't really need to do all of the laboratory tests at the same time. Maybe start with a CBC, a platelet count, a reticulocyte. A peripheral smear is very important, no? Before you do all those coagulation studies. Okay? And lastly, if there is something I want you to remember in this lecture, is for you to forget about clotting time. Okay, so that's it, and thank you everyone. I hope I was able to clarify some doubts in terms of the management of a patient with bleeding.
Okay, thank you very much, Dr. Go, for that very comprehensive lecture. Before we go to the interesting part of the program, let me just remind our attendees, if you have any questions, you may type now your questions at the Q&A box located in your Zoom panel. And then please stay with us until the end of the program to access your CPD. Yes, we will post that later on in the chat box. Okay, Doc, I think we have questions already from our attendees.
Yeah, sure.
Okay. Going back to your slide on the clotting time, we know that's already obsolete, but then we've seen a lot of referral, especially the pre-op evaluation, screening. Some of the physicians were already, the referring physicians were already ordering that. So there's a question about this, doc, from Dr. Zhao. What bleeding test do you request for pre-op evaluation?
So
I think it's referring to general pre-op evaluation test.
basic pre-op hematologic workup, no? So I would really suggest, of
Workup,
course,
yes, for the clearance.
for the clearance. For the clearance, if the patient really, especially if the patient is ready to undergo major surgery, okay. So it's really better to do your coagulation studies, not together with your CBC. Okay, so a CBC and a ProTime and APTT would be enough. No need to do bleeding time and definitely not clotting time.
Okay.
Okay, so a CBC, a ProTime and
Mm.
APTT would suffice if it's for clearance purposes. No other test.
Okay. So
No
granting
other
the
test need.
no other test.
Mm.
Okay. So I think that clarifies everything. Here's a question, another question, Doc, from Dr. Donaire. What specific vaccines causes ITP?
Actually, we know very well that vaccines we give for primary immunizations or DPT, although we seldom see these cases right now, no, with the current combination vaccines. But before we kind of really observe a lot of vaccines from DPT, usually from DPT
DPT.
vaccines which were really separate vaccines before. But I don't know if you're seeing more cases. Personally, I haven't seen a lot of these cases now with the new combination vaccines that we have.
Combination. Okay. Thank you, Doc. The next question is from Dr. Okay. We have a next question, Doc, from Dr. Guangco. What is your take in the use of ascortin in the management of epistaxis?
Yeah, ascortin. Ascortin is vitamin C with rotoside. No? So rotoside actually enhances capillary. It improves capillary integrity. So actually, they have studies to show that it helps, no, in patients who are prone to bleeding. That could be one of the things that you could use actually for patients who are having like recurrent epistaxis. So just make sure you have ruled out all the other causes of bleeding. It has actually some role.
Okay, thank you for that, Doc. Another question from Dr. Jerry Chong. In a leukemic patient, after several units of transfusion done, what is the possible reason why the blood count won't increase, especially the hemoglobin?
Hemoglobin. With transfusions, usually it's not the hemoglobin. If the hemoglobin doesn't really go up, try to look for potential sites of bleeding going on. Okay? Usually in patients who are multiply transfused, it's usually the platelet count which doesn't go up after a transfusion, like a platelet transfusion, because of development of because of the patient developing anti-platelet antibodies. No, it's a reaction to frequent transfusion. But usually, if you are concerned with the red cell value, then think of ongoing losses, or maybe there is hemolysis going on, no, which is still ongoing, which is not controlled. If it's autoimmune hemolytic anemia, which is the cause of the anemia, then sometimes no matter how much red cells you give, if there is not enough immunosuppression, then the red cells that you have given would eventually also get destroyed. But if it's not autoimmune in origin, then if you are concerned with the red cell value, try to think of ongoing losses. No, if there is no improvement in the red cell level after you have given red blood cells.
So we have to further work up this patient, doc, in cases of they did not
Always
non-respondent.
Try always to look at the underlying problem.
Okay. Thank you, Doc. Here's another question. If there is a persistent epistaxis despite the use of EpiPac and giving tranexamic acid, what other measures can we do for persistent epistaxis?
Of course, granting that you have ruled out other causes, no other hematologic conditions, ruled out coagulopathies and everything. If it's just secondary to an anatomic lesion, like a sensitive Kisel vas plexus, most often they would really respond to just pressure, no?
Okay.
Pressure over the area, and actually antifibrinolytic agents could still work, like your tranexamic acid. Actually, it still works. It will actually, because the mechanism of action of your tranexamic is antifibrinolysis. It will prevent lysis of that permanent plug that we have mentioned earlier. It will not proceed to, it will keep the hemostasis from proceeding to the fourth phase, which is fibrinolysis. That's the action of your tranexamic acid. So actually it could help, just make sure there are no other causes of the persistent epistaxis.
Or maybe there's a underlying allergic rhinitis.
Yeah, that could also be a
possibility of a persistent epistaxis, Doc. Okay, thank you, Doc. Another question, is there a difference in terms of clinical manifestation in patient with low platelet count, which is small in size, and thrombocytopenia that is large in size?
Okay, so actually it's not really there are some conditions which would present with platelet dysfunction, and size would be the platelets. Actually, if you are going to go back to basic physiology, your platelets actually come from your megakaryocytes, no? So these are actually your platelets actually come from the cytoplasm of your megakaryocytes. And the younger your platelets are, the earlier they are fragments. So once they are released in the circulation, usually they are larger in size. Okay, and the older they become, then they become smaller. And practically, of course, the younger the platelets are, the more functional they are. Okay, and it's not really the size which matters, no. It's not really the size. It's the number. It's really the configuration. I mean, it's the platelet function is not measured by the size. It's the aggregation. Its ability to aggregate will depend on substances which is actually within the platelet itself. So it's not the size which is important.
Okay, thank you, Doc. I think this was answered already regarding the use of your tranexamic acid. Another question from Dr. Donaire. In patients with APDE, aside from the avoidance of your allergens, do we maintain them on prolonged antihistamine, Doc?
Actually, for APDE, since it has some immunologic mechanisms, I mean, it is a form of an allergic reaction, then the usual advice would be to give antihistamines if there is some recurrence of the lesions. Recurrences. If there are recurrences, then you could advise them, if it comes back, then you could put them on another course of antihistamine, and it would really help. But because most of these cases really would just continuously resolve with age. It's not really something persistent. So you can give antihistamines. Your cetirizine will actually help you. It has a very high, I mean, the margin of safety for cetirizine is really very wide. So it's okay to give it over and over again.
Okay, thank you for that, Doc. Another question, is there a role of rotocide in patients with recurrent epistaxis?
Yeah, I guess I answered that earlier.
Yeah, Fernando.
Aspartame.
The aspartame, yes. The same question. Okay, a lot of questions about aspartame. Okay, there's a question about coming from Dr. Mendoza. What are the common triggers of the allergic vasculitis, Doc? Common triggers of
Yeah,
allergic
allergic
vasculitis.
vasculitis, usually it's vasculitis. Actually, it's APDE now. It's no longer acquired platelet dysfunction. I think she's referring to APDE, acquired platelet dysfunction with eosinophilia. So
Let me
usually,
think.
the common allergy is more of food. It's more of something taken in
Food.
by the patient. It's more of food. It's not something inhaled, or it's usually food related. So try to look
Okay.
at the intake, what the patient has taken in the past days, which could have triggered the condition.
Okay, thank you, Doc. Question from Dr. Tagokon. Is there any recommendation that a repeat hemogram must be done after 6 hours of blood transfusion for the correction of anemia? Exclusion, of course, among malignancy patients.
So actually, that's a very good question. No? If you really are going to look at the time wherein there is equilibration of your levels of your blood levels after a transfusion, some would even say as early as an hour after you have given the blood, there would already be equilibration of your blood values. So that practice that we use, no, of getting a repeat CBC 6 hours post VT, there is really no guideline for that. But if you look at transfusion guidelines, it will say that as early as an hour or even 30 minutes after you have given the blood, it could already equilibrate. So you could really, if you really want to know the result early on, then you could have a repeat CBC after an hour, as early as an hour after transfusion, and it will already be reflective of the hemoglobin levels, related to the blood that you have given.
Okay, so as early as 1. So no need to wait for 6 hours.
Actually, 6 hours is too long.
Okay. Um, so we see a lot of questions here. I think this has been answered regarding the role of tranexamic acid in DIC bleeding.
For DIC, actually, tranexamic is just something, it's an add-on. No? For DIC, you really have to treat the underlying disease, whatever is causing the disease, the DIC, be it sepsis or hypoxia, metabolic acidosis. Because no matter how much tranexamic acid you give, if the underlying problem is really not controlled yet, then you'll never be able to correct the uh, underlying disease, which is thrombocytopenia, which is consumption of your coagulation factors. And tranexamic acid won't really help that much if it's really the DIC is really that bad. Okay?
So it's
No
just an
matter
add-on.
add-on lang for whatever good, but it's really treating the underlying disease for DIC.
Okay. There's a comment from Dr. Maribel Chu. No, thanks for the excellent lecture. And she's asking for, I think you've mentioned before the pre-op test. How about if we do circumcision, doc? Do we do routine blood test?
Actually, for a
Circumcision?
circumcision, of course, you have to get a good history. If there is no history of bleeding
Okay.
whatsoever, there really is no need to
No need.
do all the. But if
Okay.
there is, then I mean, it's a very minor surgical procedure. You don't really need to hold the coagulation study, PVC.
Okay. I
Just
think
do.
so for the interest of time, we have to answer 2 more questions, Doc, before we end our open forum. Regarding newborn screening for babies with congenital confirmed hemoglobinopathies. Is there a support group for this patient?
Sorry, it's could you
Confirmed hemoglobinopathies, Doc.
confirmatory. So actually, that's one of the if you get hold of your
Oh, no.
hello, can you hear me?
Yes, Doc.
Am I coming
Yes, Doc.
clear?
Yes, Doc.
So that's a common
Hello,
problem.
Doc.
Hello, yes. Can you hear me? Hello, hello.
Yes, Doc. Yes,
Okay.
Doc.
So if you get
Hello, Doc.
yes, yes.
Your audio is okay, Doc.
Okay. So if you get hold of a result, no, of a newborn screening with the result nga it says hemoglobinopathy, probable hemoglobinopathy carrier. There really is actually there's a another sheet attached to it. It's a fact sheet. If you look at the fact sheet, one of the things written there is to, in terms of workup, is to do a CBC and maybe do hemoglobin. Sorry. You could actually request for your capillary, what you call this, uh, your HPLC. Your HP is a confirmatory test for hemoglobinopathies, which you could actually do once the patient reaches age beyond 6 months. No, but even if you don't do that, if you have a repeat CBC, what is usually being recommended, even by the Hematology Society, if you are given a patient with a positive newborn screening result for hemoglobinopathy, what you would advise is for that patient to return once the patient reaches an age beyond 6 months. No, it's because if you're going to review the curve, no, as to when the adult hemoglobin goes up and the fetal hemoglobin goes down, it's usually at the age of 6 months. At the age of 6 months, it's usually the adult hemoglobin would persist. If you have a hemoglobinopathy, there would be a derangement in that appearance of your adult hemoglobin. No? Your fetal hemoglobin will persist and it will be detected. It will manifest clinically or maybe laboratory-wise by a CBC. Even a simple CBC would be enough. To determine if there is a hemoglobinopathy. So what you could do in your area is to have the patient come back maybe 7, 8, or 9 months old, have a CBC done. If the CBC shows microcytic hypochromic anemia or microcytosis and hypochromia, then most likely that screening is true, no? So it's an option now whether you have an hemoglobin electrophoresis done or maybe the newer form of your so-called high pressure liquid chromatography, which is available in Manila. We can send samples to Manila for further tests for confirmation. But even a simple CBC could really give you a clue. No? Sometimes you don't even have to do confirmatory tests if the screening really shows like a specific hemoglobinopathy that is mentioned, no? Like hemoglobinopathy E trait. Sometimes you get that result, right? Hemoglobinopathy E trait carrier. And one thing probably which you should also do, which should also be done, is have a CBC of both parents. If one or both parents would show also microcytosis and hypochromia, then the more reason for you to think that this really is a form of hemoglobinopathy.
Okay. But is there a... Okay,
Mhm.
go ahead, Doc. Go ahead.
No, it's okay.
Uh, um, Presently, is there an existing support group for those confirmed cases, Doc, of patients or families with confirmed hemoglobinopathies?
Mhm.
There a
Actually,
support
in Manila,
group?
there is a support group. They call it BATHA, no? Balikatang Thalassemia. It's an old existing support group, but it's based in Manila. We don't have a local support group. unfortunately, here in our locality. So, but actually for now in our area, we see quite a number of hemophilia patients coming in, but most of them, if they are mild, if they are not transfusion dependent, then which actually is not which is not really that common. No, most of them really are of the mild forms. We don't really need transfusion support. So it's the transfusion dependent ones who really need continuous care, continuous monitoring. Some of them even need chelation therapy. So like in NMMC, we are seeing currently around 20 patients. They're not really that much, but we have patients coming in who really need frequent transfusions. So in Manila, they have a support group. They provide these patients with support in terms of transfusion, in terms of chelation therapy. We now have oral chelation therapies, although it also comes quite expensive, so that they really need some support, no, for most patients. So, but they don't have linkages yet in the province. They're only based in Manila for now. But there is an existing support group.
Okay, thank you for that, Doc. So we go now to our last question. What's the cutoff hemoglobin value for you to decide to transfuse?
Okay, so platelet transfusion trigger, before it was 8 grams, no, hemoglobin. But now, for those who are hemodynamically stable, no cardiac, no pulmonary problem, okay, so the current recommendation, we could even wait for the hemoglobin to go down as low as 7 grams, no? So the current trend now is restrictive transfusion. So the lesser you transfuse, the better. Okay? So the cutoff level has been lowered down to 7. That's for pediatric practice. Huh? Of course, it's different in adults, no, because most adults have comorbidities, no, pulmonary and cardiac-wise. But for children who have very good hearts, with very good lungs, they could really survive with lower hemoglobin levels. Most especially if the anemia is secondary to a nutritional problem, which could just be really treated with with medications, no medical, not transfusion.
Okay, so the level is 7. Have to take note of that, Doc.
Did that answer the
Okay.
Yeah.
Okay.
Sorry.
It's okay. So thank you very much,
So,
Dr. Go, for that question
any more questions?
answers. That would be our last questions. And for those who still have other questions, can they just private message you, Doc, if they have other questions concerning
They
your
can call.
share?
Yeah, sure. Yeah.
Somebody is
They
asking
can
if you have
call or they
online
can.
consultation.
Not yet. I'm still trying to learn the mechanics. It's not that easy. Actually, he's trying to teach me how.
Okay.
So maybe, hopefully.
Okay. So they've been waiting for that, Doc, your online consultation. Okay. Okay. Thank you very much. At this point, we'd like to remind again our attendees. Please take note of the house rules. We will be posting the CPD quiz link on our chat box and for you to answer later on. Okay, so at this point, may I call on our chairman of the CPD committee, Dr. Therese Habay, to present the certificate of appreciation to our speaker.
Okay, good evening, Weng. Thank you.
Good evening, Doc. Let me just share my certificate. Can you see it, Doc?
No, it's still
Loading pa.
Loading pa siya.
Let me just post this again.
Okay. I see it now, Weng. Thank you.
Okay, Doc.
The Philippine Pediatric Society Incorporated, North Central Mindanao Chapter, presents the Certificate of Appreciation to Dr. Fernando Douglas A. Go for sharing his invaluable knowledge and expertise as speaker in the continuing professional development course entitled Approach in a Bleeding Child, Relearning the Basics, given this 29th day of September 2020 in Cagayan de Oro City. Signed, Amelita Maria A. Hamoy, PPS North Central Mindanao President, Cindy Canseco Liego, Secretary, and yours truly.
Thank you.
The next certificate,
Salamat.
you're welcome. You're welcome. The next certificate of appreciation goes to Dr. Rowena G. Kawili for sharing her invaluable time and skill as moderator in the CPD course entitled Approach to a Bleeding Child, Relearning the Basics, given this 29th day of September 2020 in Cagayan de Oro City, signed by Dr. Amelita A. Hamoy, Dr. Cindy Canseco Liego, and yours truly.
Thank you so much, Doc.
Thank you, Weng.
So before we end our webinar, let me just remind you once again to please check on the chat box. The CPD quiz link will be posted there. Okay. So I'll call on once again Dr. Therese Habay, our Vice President of the PPS NCM chapter, to give us the closing remarks.
Good evening once again. First of all, I would like to thank our speaker and congratulate him for a very engaging and comprehensive lecture. Dr. Fernando Douglas Go, thank you once again. My appreciation also goes to Rowena Kawili for doing a very excellent job as our moderator for tonight. I would also again extend my deepest gratitude to Natra Farm for their unending support in our activities. To the CPD team, thank you. You have my appreciation and sincerest thanks as always. I need not mention each one of you since this is already our 5th webinar and everybody knows who you are by this time. To all the participants, thank you so much for attending this webinar. Undeniably, this pandemic has pivoted our lives in directions we have never imagined. So to somehow relieve the stress, we are inviting you to another webinar on October 8th. Please join us because we will be having a fun and relaxing session with Dr. Raisa Bayawa. So please be in your most comfortable attire during that time so that together we will stretch out the stress. By the way, I would also like to announce that our virtual Christmas party would be on December 19. Please save the date. Details will be forwarded to all the area coordinators soon. Please keep on checking our PPS NCM FB page for further announcements. So this is all for tonight. I bid you adieu. Remember to stay safe and see you next time. Thank you so much and good evening.
Thank you very much, Dr. Habay. Thank you to all our attendees. Thank you to Dr. Go, our speaker. And thank you also to Natra Farm. See you again next month for another exciting webinar. And I hope everybody is safe. So good evening, everyone, and thank you.
Thank you. Thank you, Weng.
Thanks, Doc.
you.